Okay, so it is now officially the end of an error, I guess, or era, if I guess I can say. This will be the last video before your final. I do want to say a couple things in regards to your final. I know I said I've made announcements and I put up the study guide and whatnot, but I really do want to emphasize the fact that your final, really go by that study guide, really look at it and focus on what it says. I'm really sticking true to that because it is so many questions, 100 questions in, I believe it's 2 hours. I mean, that's quite a lot of questions. I know you guys, I'm not your only final. This is potentially, for most of us, certain disorders and whatnot may not make as much sense, and you may need to, you know, I really want you not to, how would I say? Of course, it's hard to say not to stress, but to remember kind of the motto of my repetition and the fact that I really want you to like remember what we have talked about. And I'm going to wrap this up, not quickly because I don't want to teach it, but more quickly because the book does such a good job at explaining it. And this is, um, I'll give you the highlights, if you will, on what we're talking about for chapter 30. Actually 35 is the last one, so I'm going to do chapter 34 first. So let me share that screen just to make sure. I think I already was, but let's just make sure. Okay, so we are sharing that screen now, and we're going to go ahead and just start. So this chapter is focusing on nursing care of patients with the lower GI intestinal issues. So chapter 33, which we just did the previous week, had to do with the upper GI. This is the lower GI. Learning outcomes, obviously, we're going to talk about the lower GI and some potential issues that can happen. I'm going to point out the highlights, and a lot of this has to do, of course, with lower GI. That has to do more with the colon. Upper GI has more to do with the esophagus, the gastric area, meaning the stomach, and whatnot. This will also, I mean, like most times that we talk about anything with GI in general, I think it's very important to understand any type of IBS. There are several people that are suffering, especially now with all the stress that's going on in the world. We can have IBS just as like a short bout where our body just kind of responds to something, or it can be a diagnosis, there's medication. And of course, it's a psych thing. So I will mention some things about that as well. That just, I'll just say it as a side note in case I forget that IBS, the inflammatory or any type of like inflammatory bowel disorder or stomach disorder, it can have a lot to do with your mental health and how you're feeling and your anxiety level, and just, and I'm sure most of you can relate to that, as far as if you get really, really nervous, you feel like you might need to use the restroom, and it can be quite debilitating for certain people, or just have it as a physiological genetic disorder that was passed on and whatnot. So we'll talk about different signs and symptoms, of course, nursing diagnoses and all of that. Absorptions, I skipped that, sorry, up here. Absorption disorders, and where most of the absorption has taken place, which I think hopefully all of you have already read, which is mainly in the small intestine. That's where most of our digestion is actually taken in, or I'm sorry, our nutrients is actually taken in. Okay, so let's just go ahead and get started. So lower GI system in itself has to do with your small intestine, your large intestine, your rectum, and your anus. And in your book, there's plenty of pictures, and I'm sure that you've all, in your anatomy and physiology class, had gone over a lot of this stuff as well. And I have a pretty good idea of how that all looks intertwined together. A lot of this is, I mean, not that it's not important, but constipation something that I think is really important, and we went over this in some of my the last clinical I had, and I believe the one before that, mainly having to do with med surge. But even, I mean, if you're going, well, not even if, but in a lot of areas of medicine and nursing, constipation does come up, right? And I think it's important for people to understand, okay, so we hear the word Senna, we hear the word Colace, we hear the word lactulose, we hear all these different types of medications that are used to help relieve constipation. Well, what are they? Are they a laxative? And what is a laxative? How does it work? It stimulates the lining of the intestine and basically, or the colon, sorry, and basically makes it to where it causes that irritating feeling, peristalsis, and that's how you evacuate your bowels. What does the stool softener does? It extracts fluid from your intestines, colon, makes your stool soft, and evacuates. So I think that's important to really understand what medications do what and why they do what, like, and like the bulking ones, like the fiber, and why we do this. And if we're going to be giving somebody a laxative or anything that's causing them to help them use the restroom and have a bowel movement, explaining and doing that patient teaching of, if you don't take in enough water, it's not going to do the job correctly. And you can almost actually make it worse, no matter if it's a Colace, which is a stool softener, Senna, which is a laxative, Metamucil, which is, where is it? The high fiber, well, that has to do with diet, but anything that's bulking. So it's really important, I think, to understand not just what the medication is. Okay, yeah, it's going to make you go to the bathroom, but what is it actually doing, and knowing the different categories. And I think on the job too, you get to know that information. If anyone's wondering, I have a 2nd-degree burn on my arm right here. This would have been perfect for our burn conversation. And we talked about that last time, and my healing is going very well for my good nurses that did my wound care for me at the forum. So moving right along here, this is something I think that we're all very familiar with. Constipation. It's not fun. It can be caused by many different things. It could be just in general, that it could be a part of IBS. Actually, it could be stress. Your body is so clenched and you're so stressed during finals, and that can basically impair peristalsis in your colon, basically in your intestines. Opiate use, we know, even just in regular use of if someone had surgery, you're usually going to see, if somebody is on an opiate medication, that it will be paired with some sort of PRN, so that constipation will not be an issue, as well as if somebody is having issues with drug use and whatnot. It's not a fun feeling. There can be a lot of bloating going on, a lot of gassiness. It's just a very uncomfortable feeling. I'm sure every single one of us has had that. So understanding, it doesn't feel good. It makes you exhausted. It's tiring. It's not a fun thing. And then straining. We want to really watch that, right? Because what happens when we strain? We could have tears, fissures, hemorrhoids, all sorts of issues. So we want to, again, prevent before any of this happens. A little bit of what I was just talking about. So complications, we can have a lot of different things that can happen with constipation by either trying to evacuate our bowels or not going into the doctor. A lot of people, I think, potentially, at least in my experience, excuse me, I thought I was going to sneeze. Excuse me. And really, this isn't an area of our body that we tend to like to talk about, and it can be a little bit embarrassing. And in my experience, I have seen patients wait quite a long time to seek help for something that, everybody does. We all do it. This is how we rid things from the body. And it's a natural process. However, it can be something that we may not want to talk about and may avoid. So trying to, of course, make our patients feel as comfortable as possible when we're having these conversations, and watching how we're using our language and how we're speaking with them. as well as patient teaching. So like a high fiber diet, why would that work? What does it do? Why does it work? Why? And what is fiber? Actually teaching people, what is fiber? What would a food constitute as fiber? And so yeah, okay, you can eat a bunch of granola, but what does also granola have in it? Sugar. So would that be the best fibrous food that they could eat? Because we want to make sure that we are very clear in balance, right? We're not nutritionists. We are nurses. So we want to be able to, of course, give variety and give patient education. Sorry, my dog scratched my face and I just noticed right now. Fluids are extremely important. That is a huge part of constipation, as well as movement, especially when somebody has surgery and they're not up or moving, or potentially in a skilled nursing facility. And we notice that a lot. And that's why a lot of our patients in those facilities are on the medication, because they're not moving, they're not getting enough fluid. And we need that. We need that activity. We need all of these things. And education, I think, is one of the biggest things. And for many, many people. And I think many people don't even realize that they have an issue with their gastrointestinal tract until they don't have an issue, because they've lived so long with it that they've just thought, oh, this is normal. And it's not. Of course, data collection is always important. We want to determine potential histories or genetic history. Do you have problems in the past? How's your diet? What are you eating? What's your stress like? How often are you eating a day? How much fluids are you taking in? How much coffee are you drinking? How much alcohol are you drinking? If you're having, extreme diarrhea, I know we're talking about constipation, but extreme diarrhea and things are going through you so fast that you're not even absorbing the food. That can happen from excessive alcohol use. That could happen from food poisoning. We want to know what's going on, and potentially, well, not potentially, but of course, inspect and palpate the abdomen. We always inspect first. And why? Because if we palpate first, inspect, palpate, then listen. Because if we palpate, inspect, listen, then palpate, because we don't want to potentially make it where the bowel, where we're making the sounds for it. So we can kind of see what's going on in your abdominal area as far as your bowel sounds. So the opposite of constipation, of course, is diarrhea. Also not fun. And also can lead to a lot of absorption issues where we're not absorbing our food. And I know people have probably seen this before, where we actually see, we know corn doesn't dissolve or digest, but like other foods will come out and we're like, okay, wow, I just ate that came out really fast. It did not get absorbed. You didn't get the nutrients. We eat to live to eat. No, we eat to live, not live to eat. Right. So food's supposed to actually, do our body good, make us, have energy, all of that. So diarrhea, unfortunately, is not going to help us be able to absorb what we need from the nutrients of our food. It could be from several different reasons, IBS being one of them. It can go either way, constipation or diarrhea, or it's usually both. Of course, bacterial or bacteria can be in the food, like food poisoning, potential allergies to food like gluten, lactose, and we can have stomach aches and whatnot from these foods, and our body says no, get rid of it, and it just poof goes right out. Prevention, of course, is important. That's why it's important to be able to identify this as soon as possible, so that we can get it under control, so that we don't have to have our patients suffering, basically, and going through all of this stuff. It's just not fun. That feeling of that distension of the abdominal area. A lot of people have that cramping in your stomach. It's just, it's a very uncomfortable feeling. And of course, there's medications like Imodium and whatnot that can be taken, but it's a Band-Aid, right? It's different if it's one thing, you're just nervous, right? And I have to go to the bathroom because I'm nervous, or I had coffee or something. That's different. I'm talking about like chronic diarrhea. Some certain things that we can do, of course, is increasing fiber and bulking agents if needed. I just mentioned Imodium, that can help. And we can use medications. Identifying the cause is always the most important part. We always want to identify what is going on. Is it stress related? Is it a diagnosis of some sort that's going on? Is there something going on in your intestinal tract? What is happening? So being able to identify that is going to be extremely helpful. If you notice, there's 95 slides on this, so that's why I'm like not completely going to go over every slide, because some of this is pretty I think well known. Appendicitis, of course, we know we have our appendix. We don't need it. It is in the, if you ever have that pain in the right lower quadrant, we call it McBurney's point. And if we do pressure and then we let go and there's more pain when we let go, that's kind of like the ultimate sign of having appendicitis. We do not want that to burst, because that could potentially leak in toxins into the body and can be extremely dangerous. It's considered an abscess that ruptures, and you can get peritonitis, which is an infection in your abdominal area of your body. So if we do, and this can happen from several different things, definitely life-threatening, and you want to have this looked at immediately. We do lab draws, white blood cell count. We're going to do a CT. Sometimes they will just, like, depending on how the patient comes in, we'll just have them come in, open them up immediately, and as we're running the white count, just to look in that abdominal cavity and do a flush. Of course, just like with any surgery, there's going to be pain management. We're going to do surgery, potentially an NG tube if need be, and IVs, and of course, nothing by mouth. Of course, with any surgery, there's potential complications, and intestinal obstruction is definitely not something that we want. We don't want anything inside of our intestines to block something from coming out, because what's going to happen, block, and we have our intestines are feet long, right? It's a very big structure. So we want to make sure that we're getting all of everything out that needs to go out to avoid sepsis. Diverticulitis. Oh my goodness. I remember seeing so much of this on the med-surg floor when I was in nursing school, and I'm not smiling because it's a good thing, but it's such an interesting diagnosis, and it has to do, of course, read it throughout in your book, but it has to do with so there's diverticulosis and then diverticulitis. So obviously itis means infection. Is there a picture here? I want to show you. So like right here is the diverticula. It's just like a little outpouching from your intestine. And it's such an interesting thing, because a lot of the times, of course, there's underlining causes, one being chronic constipation, and that could tend to be from a lack of getting enough fiber in your diet, which we talked about earlier. And then also some other risk factors, just like with many things, of course, sedentary lifestyle, smoking, not eating balanced diet, and a lot of animal fat. And then signs and symptoms, a lot of the times until it's a problem, there really are no symptoms. You could have constipation, maybe some diarrhea, cramping, bleeding, some tenderness, some things can go on, but more so you're going to get your information when you actually are in the hospital and you have the symptoms, and that's when things are going to kind of become more relevant as far as like what's going on and what needs to be done. Definitely there's pain to this. It's an inflammation of that little diverticulum that pokes out from the intestinal wall, and it doesn't feel good. Crohn's disease is something that we probably heard the name of, but may not know as much about. I think it's good to have an idea, of course, of what we don't need to know every single little tiny detail, but I think it's important to know that Crohn's disease, it is actually an autoimmune, I was going to say the whole thing. It is autoimmune, and it's an inflammatory bowel disease, and it has to do with all of the entire intestine. There is no known cause, which is very frustrating, and it's not an easy bowel disease to necessarily control, if you will. So a lot of the times this is a lifelong battle, and there's going to be diarrhea, fluid loss, you're in the hospital here and there because you're not feeling well, then you get your endoscopy, there's a biopsy, that's this, that, and you're getting all of these different tests. There's a lot of stuff that happens with it, lots of different medications, potential surgeries, having to avoid certain foods, basically anything autoimmune, we know our body's attacking itself. So that's what's happening. So what's going to happen? Complications, malnutrition, obstruction, potential fissures, abscesses, all of these things, bleeding, perforation, and that is why it can lead to surgery. So understanding that Crohn's disease is autoimmune, so it is attacking itself, and it's awful, especially if you've ever met anyone with it and having to deal with it, as well as ulcerative colitis. Same thing. It's an inflammatory bowel disease. It affects the large intestine and the rectum, so the lower intestine, and it goes on and off, right? So it's kind of like people that suffer with IBS. I mean, some days it's good, some days it's not, and same thing, which is extremely frustrating. We don't know exactly what causes it. There's a potential kind of with our last subject was a potential autoimmune response could be a possible cause, but they're not quite sure. There hasn't been like a specific marker for that. This is not fun. I mean, liquidy stools, rectal bleeding, dehydration looks kind of similar to all of the things we've talked about, if you recall. So this is where it comes down to being able to diagnose things correctly so that we can treat them correctly, right? And that's the main thing I want to say about this, because most of this, I mean, you can read, so I want you to have that down. So IBS, same thing. I mean, diarrhea, it goes back and forth between diarrhea and constipation. There's different triggers depending on the person, gas, bloating. It's just not fun. And like I mentioned earlier, depression and anxiety can be a huge part of that. And a lot of it is history and physical for all of these. I mean, that's how we find out what's going on. And with IBS, unfortunately, sometimes we can eat and boom, we're right in the bathroom. And I've noticed, especially right now with COVID going on, I've had a lot of students ask me about that. And they're like, what's going on? And this has never happened to me before. I'm just kind of skimming through things that are pretty benign and you can read about as I explain. With IBS, like right again with COVID and everybody being so stressed and depressed and anxious has been a big problem. It's something they've never had to deal with before, and it's scary and it's not fun. It's not fun to be at work and oh my god, all of a sudden it's like I have to go now. Absorption disorders, of course, are going to be a huge issue because we need nutrients. So as it says here, the inability to absorb one or more major types of nutrients. Celiac disease, which has to do with gluten sensitivity. We talked a little tiny bit earlier about that, in lactose as well. So if we're not able to take in those, that can cause us to go to the bathroom, have a sensitive stomach, not feel well. Of course, that can lead to several different things if we have diarrhea, right? We talked about that earlier. Weakness and dehydration. All of this I'm going to skip because we can read about this. All of this obstructions makes sense. Of course, we're going to do scans to be able to see what type of obstruction is potentially happening and how we're going to fix it. And now we're moving down more to the rectum. Different things can happen. We can have hemorrhoids. There can be different things that can happen as far as cancers and polyps. If you haven't seen a picture of a polyp, I think there should be one in your book, but you can look it up. It's just and they can actually take out polyps, and that's why when they're doing colonoscopies, and why we recommend at a certain age that people get colonoscopies so that we can help treat and watch and make sure that everything is going okay. And if not, that we can hopefully try to avoid this, which colorectal cancer, signs and symptoms, which makes a lot of sense. Everything that we talked about earlier that we're trying to avoid. Colonoscopy, as I just mentioned, we can do biopsies. Of course, CT scans, different things. We can also do fecal tests to look for occult blood, meaning blood that we can't see with the human eye because it's actually in the feces and we can't see the blood. Ostomies we're, I think, fairly familiar with. It basically diverts a stool outside of the body into a different way. So there's a stoma that's put into the bowel area that goes outside of the abdominal cavity. And there's different types of them: ileostomy, colonoscopy, and urostomy. And they're basically collecting stool so that it diverts it from leaving the rectum. It leaves through the abdominal wall, which is interesting. And of course, you can read about that. I don't think that, and I mean, I will say this because I do think it's important. Knowledge deficit for sure for nursing diagnosis and being able to do the hygiene and care for it, because we do not want to get any sort of infections when we have an ostomy. So ostomy care is very important, and being able to explain to our patients what's going on with, you know, the ostomy, what it is, why they have it, how to take care of it. All of that is going to be extremely important. So we're going to now switch over to chapter 35. And this is the last chapter before your final. Oh my God, it's crazy. Okay. So this has to do with the liver, pancreas, and your gallbladder. Same thing. There's several slides. So hepatitis, of course, itis is inflammation. Hep is your liver. So this is going to be inflammation of your liver. There's many, many different reasons why this can happen. Of course, you know, I'm going to go right to this. A lot of it has to do with drugs and alcohol. That is one of the major causes of hepatitis. There can be other reasons. So I mean, you can't just say, oh, you're an alcoholic or you do drugs because your liver is inflamed. You can actually feel your liver. It can be palpated. But usually it's caused by a virus, and that's why there's hepatitis A, B, C, and whatnot. So I think that's important to understand. And there's the different ones here. Your book explains which ones are caused by which things. The Hep C is the one that has a lot to do with drug use that you're probably familiar with. And it also talks about prevention and different ones, and, you know, signs and symptoms and all of those things. Complications, very important. Liver failure, not good. We need our liver. Our liver does over 500 functions. It's a very important part of our body. If it is not working correctly, and we get to that point of maybe like fibrosis where there's, you know, basically scar tissue and we're not getting enough oxygen to the tissues of the liver, things can start not working correctly in all sorts of parts of our body. So it's very important that our liver is working to its optimal level. And it is one of our organs that is regenerative, right? But it only can regenerate so much. So it's really important. Although we may teach our patients, yes, it is regenerative. However, that's only so far, if you will. Eventually you might end up being cirrhotic, and that can lead to end-stage liver disease as well. So we have our liver enzymes, and just to mention real quick, and I don't want to go too far into it because this is my, you know, obviously area of study, like my love of my life with addiction, but liver enzymes, you know, AST and ALT are very important. Yes. However, there are so many other things that are so important that can tell how the liver is doing. And they mentioned 2 here. So prothrombin, like your bleeding time, because that's one of the 500 functions that your liver does. It helps with your clotting factors, just like your bilirubin, right? So bilirubin is basically dead red blood cells. So if your body is filling up with it, it's going to cause jaundice. And so because your liver's not able to get rid of it quick enough, that yellowish color of bilirubin is going to start to turn somebody potentially like a yellow greenish color. So it's not just liver enzymes. And I really want people to understand that. That is not the only thing that's tested, and neither are the other two, but these are just some examples. Of course, we want to prevent cirrhosis, do a lot of patient teaching, education, avoid alcohol and liver toxic drugs if that's an issue, and always identify the cause, because it may not be drugs or alcohol or whatnot. It could be cancer. It could be many, many, many different things. There are antiviral medications. So if hepatitis is part of the problem, we can put patients on antiviral medications to help with that. Hepatitis, the rest of that you can read about. And the liver failure as well. Jaundice, we just talked about, is basically a buildup of bilirubin. Bilirubin is dead red blood cells. Your liver doesn't know what to do with them. Hepatic encephalopathy is very interesting. What happens is we get a buildup of ammonia in our body. So another function of another function of your liver is to rid ammonia in your body. And ammonia is a toxin. And if your liver is incapable of doing this because it's not working to its optimal function, unfortunately, you're going to get a buildup of ammonia in your body. Ammonia is going to go throughout the bloodstream, and it is permeable to your blood-brain barrier, and it goes to your brain and can potentially cause confusion, brain damage. And if we catch it, we can fix it, right? So we can give something which is called lactulose, and that's why we give lactulose. Well, not the only reason. We may just see it because it is the strongest laxative, but it's a very sticky one and it has a lot of sugar in it. A lot of our ammonia gets caught in our abdominal cavity. So we take lactulose, and what does it do? It gets rid of a lot of that ammonia so that we can prevent brain damage. So if we prevent the brain damage, it's kind of like a palliative care, basically, until we can get things under control based on what the underlying issue is of the hepatic encephalopathy. All of this we kind of talked about before, like the bilirubin, PTT. Just read about the different causes of liver failure. Of course, cirrhosis is end-stage liver disease. I'm going to say this. It's kind of I have had patients who have been diagnosed with cirrhosis and then they don't have cirrhosis. So it can be sometimes circumstantial, where it's like, well, if you stop what you're doing, you have a 40% chance of the cirrhosis reversing. I'm not saying your liver is going to be like, oh, yay, perfect. However, your liver can potentially get better. And I think that's important to know, because I did not know that. And I actually asked a patient, I said, well, what did your GI specialist actually say? And they said exactly what I said. Oh, well, if you stop the certain behavior that is the underlying cause, you have this much percentage of potentially reversing it. So I'm not saying, or don't argue necessarily with someone if they're like, oh, I have cirrhosis, I need a liver transplant. I mean, it could be many different factors, but keep in mind that it doesn't always necessarily mean 100% like you will need a liver transplant. And that's my experience. Working in the field for a long time with this type of disease. Of course, wanting to know the etiology, what's going on. Alcohol use is the most common reason why people tend to need liver transplants, and why their livers are not functioning in the way that they should. As we mentioned earlier, itis, inflammation of liver cells. We talked about, so fibrosis in general. So basically we go from a normal liver to a fatty liver, because as a side note, your liver is responsible for your cholesterol as well. So your liver goes from a normal liver to a fatty liver to a fibrotic liver to a cirrhotic liver. That is the stages that it goes through, basically. And fibrotic is like a scar. So if people have ever had like a cut, or like kind of like in the back of your ear when you get on pierced and you feel kind of like that ball, it's almost like where you have that cut and you can feel that tissue. So that's what's happening to your liver. So at the fibrotic stage, your liver is still able to get oxygen through. It's still able to do stuff. You may still have some signs of, maybe some jaundice, some stuff going on, but you're definitely getting some impaired liver blood flow, which is not good because we know that blood flow equals oxygen. And you may notice some signs and symptoms in the gastrointestinal area. We talked about jaundice, hepatic encephalopathy. There can be definite signs and symptoms going on. Clotting defects we did talk about as well, PT, PTT, because your liver is responsible for your clotting factors, and if your liver is not working effectively, you're going to have trouble with clotting factors. And that's why we'll notice a lot of the time when we are dealing with those who abuse alcohol, you'll notice they tend to bruise easily. And that's because of clotting factors. And that's why falls are so scary, because we can have a brain bleed, right? If somebody hits their head and they're not able to clot properly, that's a very, very scary thing. That's where we come to varices and ascites. So I'm going to give you the very, and Wehrnick-Korsakoff's. Oh my God, this is like my dream right now. Oh my God. Okay. Not dream, sorry. But like, this is my thing. But I want to do this in brevity so that you remember it. So this is what I want you to remember. Yes, there's portal hypertension. So your liver in itself will have hypertension, if you will, because there's different vascularity to it. You'll read that in your chapter. What I want you to think about is this, ascites. First of all, what is ascites? Ascites is that, okay, you have your peritoneal cavity. That is your abdominal cavity. That is our largest cavity that we have. Where's your liver located? In that cavity, in the right upper hand quadrant. So we have this happening. We talked about earlier that, well, we didn't actually, but your liver is responsible for the creation of one of the largest proteins in your body called albumin. Albumin is responsible for keeping your vascular fluid where it belongs. So like when someone has edema, that could be from several different issues, but this is just an example. So if I don't have enough albumin in my body because my liver is not able to produce enough albumin in my body, and then I have this portal hypertension, basically I'm not able to keep my vascularity or the vascular fluid where it needs to go. So where's it going to go? It's going to get pushed into the big cavity next to where your liver is. And where is that? Your abdominal cavity. So you get all of this fluid buildup. And that's where people will look pregnant and they're not. I mean, we can pull out 3 to 4 liters of fluid. Most of you have had this question from me when we practice NCLEX, especially in psych. And that's done by a paracentesis, large lumen needle stuck in the abdominal cavity via ultrasound. And that fluid is taken out. That is palliative care. That fluid will come back. But that is what ascites is. Varices has to do with your esophagus. We have vascularity in our esophagus. And if we already know that we have this underlying stuff going on with our liver, we will have our GI doctor already looking down in here to make sure, because this is the number one reason why people will die, is because what happens is we don't have our clotting factors, right, as well as they should. And then we have these varices in a very vascular part of our body, and your liver, by the way, is very vascular. And normally we'll go down and we'll cauterize them. So we're already doing it. But if we don't go to the physician or something happens, or it could just happen, they burst and you start bleeding and you don't stop. And it is, I've only seen it once. It is absolutely terrifying. It is awful. It is not, I mean, I don't think any way to die is necessarily good, but it is just awful to see. It's heartbreaking. I mean, you're pushing in all the blood factors that you can, but it happens. And so it's important to understand what varices means when we're talking about the liver as far and ascites. And that's another reason why sometimes that you'll notice also edema on the lower extremities. Hepatic encephalopathy we talked about. The only other one I really want to concentrate is Wehrnick-Korsakoff's. I don't like this word, wet brain, but I'm going to use it because I think that's the one that's the most common that people understand. And sorry, just checking my phone. Students are texting me. Okay. So Wehrnick-Korsakoff's is referred to as a slang term as wet brain. And what that means is, if you're my last clinical, you know, So we have this vitamin, it's called thiamine. Thiamine is a vitamin B1. We do not produce it ourselves. We must intake that vitamin with it's in food. So we have to eat it. So with somebody who has issues with alcohol, usually, I'm going to use alcohol just as the example. Let's pretend, well, it depends on the person. Number one, sometimes it's just they're replacing their calories with alcohol, so they're not eating, so they're not getting enough vitamin B1. If you're not getting enough vitamin B1, which is thiamine, it's extremely important for brain function and can cause permanent brain damage. It's a spectrum, of course, so depending on where you are on that spectrum. Or you are eating, however, you have so much hydrochloric acid, or sorry, back that up. You have so much alcohol mixed in with that the alcohol actually breaks down the thiamine, and your stomach is not able to absorb the thiamine. So your brain's not getting it, and your brain depends on it. Otherwise, again, it can cause brain damage. So that's what Wernicke-Korsakoff is, and it is referred to as wet brain. So if you've heard of that, that's what that is. So the difference between really this and hepatic encephalopathy is, in my opinion, this one's much easier to treat and not usually it doesn't stay when it's not where there's a cure, if you will, or palliative care, where Wernicke-Korsakoff, once you have it, you can't reverse it. However, you can stop it, if you will. Like I've known lots of patients that have just a little bit of it and you can tell, but they can take care of themselves still at that point. Portal hypertension, you guys can read about. Cirrhosis, these are all the ones. So these are all like the ammonia levels, like we talked about, right? So if hepatic encephalopathy, I'm going to test, like, it's not just about the enzymes. There's many other things. What's your PT level like? So if I have someone that comes into the ER and I'm like, oh my God, these levels are off the chart, their enzymes might actually be not that bad, but all this other stuff is way off. And I'm like, okay, that points to the liver, because I know the liver is responsible for these other functions. It happens all the time. Cirrhosis, like diuretics, of course, that makes sense because we talked about edema, sodium restriction, because we know the water follows sodium. Albumin infusion, we talked about albumin. Why? Because albumin is going to help to put your fluids in your body in the right compartments of where they need to go. We talked about esophageal varices, hepatic encephalopathy, lactulose. We talked about that. That's one of the main medications they give because it's, again, made of sugar. So what's it going to do? It's going to stick to that sugar in your abdominal cavity, mainly in your intestine. You're going to have several bowel movements a day. It's very life altering, but it keeps your brain from having brain damage. Liver transplant is usually, it's going to be the cure for liver failure. And anti-rejection medications, of course, because of a transplant, are going to be given. So all of this we can read. The other stuff I think was some really important stuff. So pancreatitis in general is basically autodigestion. So what happens is so you have your pancreas, and your pancreas in the big picture basically spits out juices to help you digest. And so when those juices are in the pancreas, they're turned off. When you eat and excuse me, your body knows it's time for them to spit out, they spit out. That's how your body is supposed to work. Unfortunately, with pancreatitis, the juices start to turn on while they're still in the pancreas, and it can actually auto-digest, like digest your own pancreas. It hurts like a something from what I've heard, and it's awful. And it's actually very much related to alcohol use disorder. A lot of people, that's one of the first things that we look at when people, right here, alcohol, when people come into the ER. So keeping in mind that your pancreas is not supposed to turn on unless it spits out. So when the pancreas juices inside the pancreas, it's turned off. Once it spits out, it's turned on. So it helps you digest. That's the key. All of this you can read on your own. Chronic pancreatitis, of course, is not fun, and it can lead to tissue death, right? Because I mean, it's happening all the time, and it usually is. It's either idiopathic, which means why we don't know, it just happens, or it has to do with alcohol use disorder. And we do a lot of patient teaching about that, and people, I mean, once they get it, oh my god, and they're much more likely to get it again. It hurts so bad when you hear people talk about it. And of course, cancer of the pancreas, we all have probably had some exposure to this. It's one of those cancers that doesn't have any signs or symptoms. So by the time that we realize we have it, unfortunately, the rate of living from it is very, very rare. It's usually caught because they've done some sort of scan on something else, and then they see it, and then it's unfortunately too late. Gallbladder disorders, no fun. It hurts. There's gallstones that can be removed. The gallbladder is often removed in more people than we would maybe think of, but it is kind of a common surgery. It's not fun. Your gallbladder is important. I mean, it has a lot to do with digestion, and then we have to change our diet. And there's, of course, lots of tests done. The gallbladder has to do with bile, again, which has to do with digestion. And we do an ultrasound, we do different things, and it might need to be removed. And then you have to change your diet. So I'm hoping from all of this, we get, I mean, again, you are all very intelligent. You can read. I more wanted you to get like the highlights of, okay, the liver does this, it does, and the pancreas, and kind of the stuff that it doesn't say, and get a better picture of it. And I hope you enjoyed this video, our last video together. And I just want to say that I'm really, really proud of all of you for being able to sustain throughout this year, sticking with me, doing everything that we've done together. I mean, I'm human just like you. I'm doing the very best I can. You're doing the very best you can. And I'm here for all of you. If you need anything, recommendation letter, someone to talk to, help, anything, let me know. And I hope that this helped. If you need anything, let me know. If you have any questions, I'm more than happy to help. And you're going to all do great on your finals. So I'm going to stop this and get it posted. Thank you so much.